first talk of the session is on approaches of joint arthroplasty in rheumatoid arthritis patient.
ये चेंज कैसे इसमें है ठीक है ना. Good afternoon, one and everyone gracing this occasion. So, deliberating from this podium on a subject entitled Approaching Knee Arthroplasty in Rheumatoid Arthritis. The basic difference between a surgeon and Arjun is Arjun used to look after the eye, but as a surgeon we are bound to look after not only after the eye, we need to look after the fish and then target the eye. So, the objectives covered will be the pre-operative as well as the intraoperative considerations, with a particular focus on complications, because it's always better because it's an old adage that if we fail to plan, we plan to fail. So better to foresee all the complications, have the armamentarium ready, and be ready to tackle such things if it happens. Knee is one of the commonest joints to be involved in RA. Joint destruction is more common despite advances in medical treatment, and hence various precautions and planning are needed for achieving an optimal outcome. RA is quite different from OA because it affects younger patients. The skin is friable, osteoporosis is more pronounced, leads to immunocompromised situation, prolonged reduced function, and needs a prolonged rehabilitation phase. The pre-operative considerations to be taken are the age and the activity of the patient. It involves multiple joint and the patient is already on multiple medications. Comparatively younger than OA patients by about a decade, evaluation of knee function should be based on physiological age of the patient. The patient lives a normal lifespan. Hence, longevity of implants should be taken care of by adequate planning, both pre-op as well as the intra-op. There are few papers by the legends, by the living legends like maybe C.S. Ranawat and Scott, which says that total knee arthroplasty in a group of patients less than 45 years of age has as good as an outcome if it is done in the elderly. We should be inspired with this, but not be over-inspired, because these were the surgeries and the paper done by the legends. We need to have an optimal experience to come to such conclusion and to have such things. Multiple joint involvement, knee and hip involvement concomitant is about 50% in rheumatoid. Usually hip to be replaced first because it allows knee flexion for TKR and also an improved rehab. Cervical spine has basilar invagination chances. It has, the patients may have atlantoaxial instability, subaxial instability in about 61%, have radiological signs such. So they need evaluation to avoid neurological compromise, particularly during intubation. It has a very common upper limb involvement which may preclude use of assistive devices during our rehabilitation. Few radiographs. Medication history involves usually NSAIDs, steroids, disease-modifying anti-rheumatoid drugs and biologicals. NSAIDs inhibit platelet function which affects wound healing, usually discontinued for 5 days prior to surgery, though it is controversial, and nowadays many anesthetists do not recommending a discontinuation even. Aspirin usually discontinued for 10 days before surgery, COX-2 inhibitors being an exception. Steroid use is very common in India, more from quacks. Role of rheumatologist comes here into play, and exposure, higher glucocorticoid exposure is more likely to have hyperglycemia and other complications, so its judicious use is to be precluded. These are the recommendations of avoiding or to stop the biologicals and the DMRDs in total knee arthroplasty, the guidelines. So the intraoperative considerations include the bone quality, the soft tissue, and the deformities. Osteoporosis is a disease process itself, plus it is complicated by use of steroids. There is subchondral resorption due to cytokines from the hypertrophic synovium in rheumatoid. There is significant bone loss in many cases, for which needs graft or modular prosthesis, the subchondral cyst may need further bone grafting. The soft tissue status, steroids and poor nutrition may further aggravate poor wound healing, plus increased risk of surgical site infections. It's a disease of active synovitis, so total or near total synovectomy is to be considered. Ligament failure may demand use of constrained prosthesis. Fixed valgus, options available with increasing severity of the deformities are gradual lateral release, pie crusting, division of iliotibial band, or LCL division at the femoral origin. Flexion deformity, options available with increasing severity of the deformity based on patient to patient, serial casting pre-op, posterior soft tissue release, avoid excessive distal femoral resection as it may lead to elevation of joint line and mid-flexion instability. Up to 1/3 flexion deformity can be left in few cases. That is to be recovered by a proper rehab. Condylar deformities pose difficulties in achieving correct femoral prosthesis rotational alignment. There is a significant tibial bone loss in quite a few cases, which leads to difficulties in tibial resection. Adequate experience in routine TKR is needed to avoid the above problems. The important post-operative considerations are more serious complications than TKR for OA. Surgical site infection is 3 times higher. Delayed surgical site infection is 5% at 7 years post-op. There is increased risk of periprosthetic fracture, and due to steroid uses and poor bone and soft tissue quality, they poses inherent risks as post-operative complications. So to summarize, TKR in rheumatoid can provide good functional outcomes in carefully selected patients. Rigorous pre-operative planning is required. It demands a team approach involving rheumatologists, orthopedic surgeons, anesthesiologists, and physical therapists. Wise use of steroids and DMRDs is required. Despite all this, we can have high complication rates. Thank you.
Thank you very much, Vishal, and very insightful talk. Any questions from the audience? Anything, or somebody wants to add anything to the talk? So, there is always another problem that we are commonly facing is that patient is getting injection, intra-articular injection. That's another that you need to poke the patient. Patient may not tell initially, and just before surgery, maybe a night prior, they will just inform you that, okay, this patient has. So that is something that you need to be very aware of, because you may want to avoid it maybe 3 months or 8 weeks, 12 weeks. So that is one. Otherwise, people take all sorts of medications, so you just cannot do anything. And anything else? Any other questions to him? Okay, thank you, Vishal.
Thank you.
So next I'll call upon Dr. Vasu Suresh Bhai for his talk on